Good day, and welcome to our series of lectures and demonstrations on the South African maternity case record. And in this instance, it's going to be about the new partogram or the interim partogram as contained in the updated maternity case record, and includes everything about intrapartum care. This is the reality of obstructed labor, uterine rupture, fetal death, and this is what we'd like to avoid, a neglected, long drawn out labor process. On the other hand, the numbers of caesarean sections are rising in almost every province in South Africa, and if you look at the South African average, every year there are more caesarean sections done than the previous year. One way of monitoring the progress of labor is to do this graphically using a partogram or partograph. And this is the new interim partograph that is in the South African maternity case record. It's just slightly different than the one that was there before. And in this demonstration and lecture, I'll tell you about the new interim partogram, why it's called the interim partogram, and how to use it in labor. But clearly we just need some form of documenting the progress in labor, so whatever partograph or partogram you're using, it's better than not using any one at all. So let's start with the first stage of labor, the active stage of the first stage of labor. We are used to the partograms that's been in use for the past 30-40 years, based on research by Friedman that suggested that the active phase of labor starts around about 3 centimeters of cervical dilatation and then progresses about 1 centimeters per hour. And later Professor Philpot added the alert and the action lines on the partograph. But in the last 20 years or so, there are many studies to suggest that this is not as predictive in every woman. And in fact, in the current generation of women giving birth, this might not be accurate. And this was all summarized in the WHO Better Outcome in Labor Difficulty project done a few years ago. And it's quite clear that the dilatation rate of 1 centimeter an hour is inaccurate to identify women at risk for adverse outcome. And it's in fact unrealistically fast for most women. And labor may not naturally accelerate until the cervix is about 5 centimeters dilated. This is a study that you can download if you want to read it. It's progression of the first stage of spontaneous labor in 2 sub-Saharan African countries, a very large study done and published in 20. So in this specific study, it was a prospective multicentre cohort study in Nigeria and Uganda. There were more than 5,000 women with single baby, vertex, term gestation, presented below 6 centimeters vaginal cervical dilatation with spontaneous onset of labor, and that resulted in vaginal birth with no adverse birth outcomes. And in a follow-up study, they also looked at the bad outcomes. And I'm going to show you this graph. There is the warning line or the alert line and the action line as would be in the traditional partograms. And it's first going to show you the good outcomes in grey, and then superimposed on that the red outcomes. And as you will see in the end, there are many women in the grey area here with a good outcome, but with a very long labour, which would have received caesarean sections most likely in our setup because they crossed the action line. And there are just as many women that actually progressed quite well on this side of the line, but had a bad outcome. You can see first the good outcomes. And now those with bad outcomes, meaning the baby had some sort of problem, but labour actually in most of them progressed quite normally. So the main findings from these type of studies is that labour is actually slower than we generally accepted. It's much less than 1 centimeter cervical dilatation per hour, and once a woman gets to about 5 centimeters cervical dilatation, it gets much faster. There's much variation between individual women, so it's not that easy to make an average curve that is applicable to all women. If we look from these studies at the average duration of labor, and this is for labor that starts at 4 centimeters, this is exactly what it says. So slow dilatation initially, and once you reach 5 centimeter, quicker dilatation. So this is for different parities. Another way of looking at this is to look at the 95th centile. So this is the slowest of the slow but yet normal, 95th centile. And look, for example, somebody that started at 5 centimeters dilatation can be up to 6 hours before it goes on to 6 centimeters, then another 2 more hours before carrying on to 7 centimeters. So most women will progress over here, but this is the slowest that is still acceptable, still normal, good outcome, but the 95th centile. This is a systematic review of many of these studies that looked at the duration of spontaneous labor in low-risk women with normal outcomes. So this is now adding more and more and more studies to do a combined analysis. And at this stage, or a stage when it was published, more than 200,000 women could be included in this meta-analysis with more than 37 studies. And they all found that the median duration of the active first stage, so starting from about 4 centimeters, can be quite long, up to 6 hours. And if you look at the 95th centile, that's the average, the 95th centile can be up to 16 hours. If you look at the active phase and recorded it from 5 centimeters dilatation, the median duration of labor was still 3 to 4 hours, and the 95th centile up to 12 hours. The recommendations that I'm going to discuss today are all in this World Health Organization recommendations for intrapartum care for a positive childbirth experience, and you can download the full document from the internet if you're interested in reading it. But I'll give you the summary that's applicable to South Africa. So this is the sort of thing that we would like to prevent. And if you just look at this partogram, it's one of the older partograms that started at 3 centimeters with the active labor. So this patient was 3 centimeters dilated with a cervix that was still 3 centimeters long. 4 hours later, head still high, still 3 centimeters dilated, cervix had shortened a little bit. Now she was transferred to the active side. 4 hours later, cervix still only about 3 centimeters dilated, head has come down to 3/5, cervix still 2 centimeters long, and 2 hours later, because she's now crossed the action line, the patient has gone for a cesarean section. But in fact, if we take into account everything that we've read up to now, this patient was not even in active labor yet. The cervix was only 3 centimeters dilated, it was still 2 centimeters long, so not effaced. There were still only moderate contractions, so this patient was not in active labor yet, and most likely had an unnecessary cesarean section. As a summary in the WHO care guideline, taking all of this evidence into account, there's insufficient evidence at the moment to support the use of an alert line, because it doesn't really detect women at risk of adverse birth outcomes. So in hospital settings, this might lead to unnecessary cesarean sections. But we should continue to plot cervical dilatation versus time on any form of graph. That's what I said in the beginning, so that we can see if there is any problems with the birth process itself. So if you work in a clinic where you cannot do augmentation or cesarean sections, and it's like in our setup where it's difficult to reach the next level of care because of long distances involved, then the alert line could still be used to triage women who may need to be referred for additional care. So if we work according to this with the new evidence, plotting should commence from a cervical dilatation of 5 centimeters. So when women are really in the active first stage of labor, and if then after 2 hours there's not good progress, they might need to be referred to the next level of care. This is the partogram, or any partogram that's been in use so far, with the alert and the action line. And over the years, the action line has been wrongly interpreted as the must deliver immediately line, and if you don't do any action after the action line, there is going to be serious consequences. But in fact, even when Professor Philpot in 1972 described the action line, he said that when the patient crosses the action line, the action you should take is to make sure there's no cephalopelvic disproportion. If that's excluded, give a 6-hour trial of oxytocin, only in primo-gravidis. Make sure the patient is well hydrated, give epidural block if necessary. But if all of this fails, or if there's fetal distress, then do a cesarean section. So the action was never straight away at delivery. The action was always reassess the patient, rehydrate the patient, see if there's anything that you can do to expedite labor. Since 2003, the Department of Health had the action line at 2 hours away from the alert line, and in fact for a time we had a few lines, a warning line, a refer line and a review line. So this 2-hour line functioned as a line where you can refer patients from a lower level of care to a more advanced level of care in case she needs to have a few hours in transport before she gets to the review line. But the partogram is not just plotting of cervical dilatation over time. There are many important aspects that we should not forget about. And the one is the position of the head, whether it's anterior or posterior. The other important one is the head above pelvis, to see how the head descends. To know exactly what is happening with the head, what is the application, what is the presenting part, is there signs of caput and molding. And then also to look at the fetal heart rate, if there are decelerations or not, how strong are the contractions. All of this needs to be taken into account when we do an evaluation of progress of labor and not only cervical dilatation. So there are then two ways that you can record labor progress on a graph. One is the way we've been using up till now, which is the straight line with cervical dilatation in centimeters, and the so-called action line partograph, or the 95th centile way of recording it, which would probably be the new way that we are going to go in future. And the little stars there show you where normal progress or average progress would be for both of these. So the moment you've got two options in medicine, we always do a multicentre randomised control trial to see which one is better. And this was exactly that was done in this study, and it was published in 2018 as well. And in this, they compared the outcome using the straight line or the so-called action line partogram in some hospitals, and other hospitals that used the 95th centile partograph. And what was interesting is that they did not find any significant difference in the use of intrapartum cesarean section between the two units, regardless of which partograph they used. But in both, there were a decrease in intrapartum cesarean sections. And they explained this by the fact that people were now paying much more attention to their labor progression. So they were looking at all of those things that I've just mentioned, the head above brim, the contraction pattern, the molding, the whole movement of the baby through the birth canal. And all of these is important to try and monitor labor and prevent unnecessary cesarean sections. And in fact, if we take these two different options and we put it on our existing partograph, this is the sort of average curve, this is the 95th centile. You can see that it fits more or less into what we are doing at the moment, having a review line that is 4 hours apart from the warning line. And this is how the new partogram looks. It's very much like the old one. The main difference is that the active phase of labor now starts at 5 centimeters with full cervical dilatation. The fetal heart rate is plotted in beats per minute, and you have to add decelerations, yes or no. And there is still a 2-hour line to the right of the action or the alert line, and this is the line where we need to refer or call the doctor or take some action in case the patient is not close to care, and I'll come to that in the detail. This is the partogram that is in the maternity case record at the moment. It is called the interim partogram because most likely we will be moving towards piloting and implementing a stepwise or a 95th centile type of partogram in future. There was an Intrapartum Guideline developing group, and the consensus from all the research and the WHO recommendations was incorporated in this manual, and I'll show you the manual just now. The latent phase can now last up to 24 hours. That's from the diagnosis of labor up to and including 4 centimeters. But if a woman is in the midwife obstetric unit or a unit that cannot do cesarean sections and she's in latent phase for up to 12 hours, she can be referred to the next level of care if she hasn't reached 5 centimeters yet. And then, as I said, the alert line will start at 5 centimeters. And this is the Intrapartum Care Manual for South Africa, updated in March 2019, and it is available for download, and you can click on the link next to this lecture. The guideline says that vaginal examinations in the active phase of labor have to be done 4-hourly till about 8 centimeters, and then you can do them 2-hourly because it's then closer to full dilatation. So it's not necessary anymore to do vaginal examinations every 2 hours. When should it be necessary to do them more frequently than these intervals? Obviously, if there's a fetal problem, if the internal fetal condition is non-reassuring, or if the woman in the meantime has an urge to bear down. And when do you need to refer to the next level of care or call a doctor if you are at the next level of care? Again, if the maternal fetal condition is not reassuring, if there's meconium stained liquor and the patient is not about to deliver, or if there is real slow progress of labor. So how do we define poor progress in the active first stage? If you're in a clinic without a cesarean section facility, then when you cross that 2-hour review line, and remember, if you start counting at 5 centimeters, the median duration of labor is less than 4 hours. So in 4 hours, the patient should be at least 9 centimeters or fully dilated almost. If it is in hospitals with the capability to do cesarean section immediately, we would call poor progress if there's no progress with the next examination. And at this stage, you have to exclude cephalopelvic disproportion, make sure there's good contractions. If the membranes are not ruptured, rupture them. And if there is no CPD, then to augment with oxytocin, especially if it's a primigravida. So how to use the partogram in labor? Firstly, make sure the patient is really in labor. And the definition is easy, but it's very easy to make a mistake as well. There should be regular painful contractions, at least one every 10 minutes, and these contractions should lead to something, either cervical changes, cervical effacement, or rupture of membranes. Then the patient is in labor. The first stage of labor, the latent phase of labor, so you've made the diagnosis now, you can plot on the left-hand side of the partogram. And there is space for 12 blocks. So you can use one for every 2 hours, so you can fit in the full 24 hours on this side. And this is from the onset of labor until labor reaches 5 centimeters. And as I said earlier, this can last about 24 hours. The moment there is 5 centimeters cervical dilatation, we plot the patient on the active phase of labor, and this active phase is from full dilatation until the head is on the perineum. So during the active phase of the first stage of labor, you would expect quite well progress to happen like this, because this is sort of the average curve. And then when patients crosses the we have to try and find out what needs to be done. So at this stage, a doctor, or at least an advanced midwife, must evaluate the patient and find out the reasons for slow progress and address these. It's very important to look at descent of the fetal head. So that's why every vaginal examination should be preceded by an abdominal examination. And if the head does not descend, but there is dilatation of the cervix and there is improvement in the stage of the head, this may be molding of the head due to cephalopelvic disproportion with lots of caput. So the moment the head is less than 2/5, you have more or less excluded disproportion at the pelvic inlet, because the largest part of the head is now moved into the pelvis. And it's important to plot the descent of the fetal head using the circle, and this head was 5/5, this head was 3/5, and now it is 1/5 above the pelvic brim. So we all know the rules of peace, but I'm just going to go through it again. So when you examine a patient for slow progress, start with the patient herself, make sure she's comfortable, she's mobilized, she will have support from a partner, bladder is empty, good pain relief, and she's not dehydrated. Look at the uterine contractions. So are they either inadequate or are they not effective? And in both cases, oxytocin might help. Then look at the passenger or the baby itself, and this is where we really need to know exactly how the baby is moving through that birth canal. So what is the lie, what is the presenting part, how big is this baby, is it not perhaps undiagnosed twins, and has the head engaged or not? So if it's 3/5 or more, the head has not engaged yet. And finally, look at the passage itself. It may be that the membranes are not yet ruptured, or it may be that the pelvis is totally inadequate. We diagnose cephalopelvic disproportion as a cause for slow progress when the head's still 3/5, so the head is not engaged, there's 3 pluses of molding, and you feel a small pelvis on examination. And this is a classical picture of cephalopelvic disproportion. And you can see that this head is still 3/5 above the pelvic inlet. And you can see the molding there, the parietal bones overlapping and the parietal and occipital bones overlapping, and that would be 3 pluses of molding. So let's look at another example of a partogram, and in this case, maybe you would just like a minute to look at the partogram. Let's look at it in a bit more detail. The patient was 4 centimeters dilated at 11 o'clock. With the head 3/5 above brim. They've documented as a left occipito-posterior with 1 plus of caput and 1 plus of molding. Fetal heart rate before and after contractions were the same. An hour later, the fetal heart rate starts to show early decelerations. At the next vaginal examination, the head is still 3/5. The cervical dilatation is now 6 centimeters. But there is caput and there is molding, 3 pluses of each. So at this stage already, we can call this cephalopelvic disproportion, a head that is 3/5 and 3 pluses of caput and molding. But be it as it may, in this case they decided to wait another 3 hours, and now we still have a head that has not descended more than 3/5, only 7 centimeters dilatation, and still 3 pluses caput of molding. So you can see that overall cervical dilatation was not so bad, but the head didn't descend, caput and molding presented, and in fact if you look at the fetal heart rate, you can see that there were late deceleration since about 2 o'clock in the afternoon, with the heart rate before the contraction 150 and a heart rate after the contraction 130 beats per minute. So with these late decelerations and cephalopelvic disproportions, this patient should have had her cesarean section at this stage already. This you can practice in the skill station, and this is just looking at head above brim, and it's important to distinguish 3/5 where the head is not engaged and 2/5 where the bulk of the head has gone through the pelvic inlet and only 2/5 are palpable abdominally. Let's move to the second stage. So when does the second stage then start, and how long can the second stage last, and how should we monitor the fetus in the second stage? If you look at the statistics in South Africa, if you look at the Saving Babies report of 2018, you see that there was almost 3,000 perinatal deaths due to intrapartum asphyxia in South Africa, and most of these were large babies, more than 2 kilos. So the top 3 causes of deaths in babies in South Africa is prematurity, asphyxia and infection, and of these, asphyxia we can prevent as far as possible. So now the question is, when does the second stage really start? Is it when the patient is 10 centimeters or fully dilated, or is it when she starts pushing? And there are many societies right over the world. So this is the British one, this is the American College, the Federation of International Gynecologists and Obstetrics, and the WHO, the World Health Organization, and many of them have different definitions. But the one that we are using in South Africa is the FIGO consensus statement, which says when the patient is fully dilated and pushing. And we start counting the second stage when she is fully dilated and she has the desire or the urge to bear down. The American College clearly states that there is no specific absolute maximum length of time that we can spend in the second stage of labor, that you have to draw the line and say after this every woman must have a cesarean section. So that has not been scientifically determined. So if we say it starts when the woman has the urge to bear down, how long can she push? So traditionally in South Africa we've said 45 minutes for first baby and 30 minutes for second baby or more. Using the evidence from the studies from the WHO BOLD project and all the recent ones I've quoted, some say even that women can push for 3 hours, and if she's multiparous she can push for 2 hours before we need to call it a prolonged second stage. What are we going to do in South Africa? Let's look at the evidence. So the evidence for nulliparous women is that the median, so the sort of the average of pushing in healthy babies is up to an hour, 66 minutes. But the outliers of the 95th centile, which is still be regarded as normal, can be up to 2 hours. If it's an epidural, it goes more, almost up to 3 or 4 hours. And if a multiparous woman usually pushes 6 to 30 minutes, but the 95th centile can be up to 78 minutes. So again, 45 minutes might be just too quick to allow a woman to push in the second stage of labor. But it is an exact science because we don't know exactly when the second stage starts. If we do a vaginal examination, we find it's 10 centimeters or fully dilated. It might have been like that for the past hour or 2. We don't know exactly when the woman is 10 centimeters dilated. But what we do know exactly is when she feels the urge to bear down, even though she might feel that urge before complete dilatation. But if the cervix is fully dilated and there is the urge to bear down, that's when we can start counting the second stage. So there's no grounds for intervention in the second stage. If the woman's condition is satisfactory, the baby is fine, and there's continuous evidence of progress, the head is still descending through the birth canal. And as I said, the World Health Organization says 3 hours for a nulliparous woman and 2 hours for a multiparous woman. So for South Africa, it decided the following. If the woman's cervix is fully dilated but she still does not have the urge to bear down and she's not actively pushing yet, we can give it another hour for the head to descend. In this time we must just rule out cephalopelvic disproportions, and you can still use the partogram to plot the observations as you would have done during the second stage of labor. The reason for this is that under normal circumstances, once the cervix is fully dilated, the baby still undergoes the same stress as during cervical dilatation. It's only once the woman starts to actively push down that the baby has periods of decreased oxygenation due to the birth process, and this is now when you have to step up your observations of the fetal heart rate to every 5 minutes. So fully dilated, but still not a desire to bear down, the head is still descending. You can continue to monitor the fetus as during the second stage of labour. So in the South African Intrapartum Care Guidelines, you'll see that we've defined the second stage of labour from where the woman starts to get the urge to push. And once she starts with active pushing and you're in a unit that cannot do cesarean sections, meaning you have to refer, you can give her 45 minutes if it's her first baby, and for any multiparous woman 30 minutes of active pushing. And then after active pushing of 30 minutes in a multiparous woman, or 45 in a nulliparous, nothing happens. She can be referred, and we still have that hour or two to play with before she gets to the next level of care. If she is pushing in a facility that can do a cesarean section immediately, 24-hour on-site facility, if it's a first baby, can push for up to 2 hours, but you should call the doctor at least at 45 minutes to evaluate the patient to make sure there's not any missed problems. If it's a multiparous woman, she can be allowed to push for 1 hour, but again call the doctor at 30 minutes. But in all cases, just to be safe, if she starts to push or actively bear down, but nothing happens in the first 15 minutes, just get senior help to come and assess and see if there's anything that can be done. As I said, we have to step up observations of the baby once the woman starts with active pushing. And again, you don't have to read the detail on this slide. There are many societies right over the world, and almost all of them says every 5 minutes, at least every 5 minutes. So that's also adopted in South Africa. So at least every 5 minutes during the bearing down phase, look at or listen to the fetal heart rate. So intermittent auscultation with a handheld Doppler or with a stethoscope, and at least before and after every second contraction. If it's a high-risk patient, you can do a continuous CTG, but the CTG during this bearing down phase of the second stage of labour is very difficult to interpret. Usually the best thing to look there is for a direct return to the baseline after every bearing down effort. If there's not a return to the baseline, there might be decelerations. So we do it every 5 minutes or after every second contraction, whichever comes first. And this is just a graph to show you, or a graphic to show you intermittent auscultation. So if you listen to the baseline here, the patient has a contraction, she's got another contraction, 5 minutes later you listen to the heart rate again and you find the same baseline, and this will be good. If at this stage you find a different baseline, there might be decelerations. So at least after every second contraction you have to listen again, or every 5 minutes. As I said, in the second stage, the important question is there a normal baseline heart rate? And does the heart rate return to baseline between contractions? And this is a demonstration of a contraction with a deceleration. This is why I have to listen after the contraction. So if you listen here, you'll pick up the deceleration. If you wait too long to listen to the heart rate, you would miss that contraction because you've listened at this stage where the baseline has returned to normal. So check the baseline before a contraction and directly after a contraction or every second contraction.